Welcome everyone to Ask NEI. Ask NEI is a monthly live Q&A where you can get your clinical questions answered. I'm Dr. Debbie Ann Morissette here at the Neuroscience Education Institute, and we are absolutely honored today to have joining us the amazing Dr. Christine Moutier, Chief Medical Officer of the American Foundation for Suicide Prevention. She is here today to answer your questions about the new 988 Suicide Lifeline and suicide prevention. Welcome, Dr. Moutier.
Thank you so much, Debbie. And I'm so, honored to be here and flattered by your introduction, but it's great to be here with the NEI community. And I'm really excited to hear what your questions are.
All right, so we only have 30 minutes to answer questions. So let's jump right in. We have a few pre-submitted questions, but also to our audience, feel free to submit your questions into the chat. So first question for you, Dr. Moutier, is 988 just for those who are feeling suicidal, or is it also for people who are concerned about a loved one who is exhibiting suicidal behavior?
988 is for both people who are in distress, as well as for anyone who's in a helping position with that individual. That could be a family member, it could be a counselor or guidance counselor, or any helping person. A youth pastor can call 988. And just one point of clarification, 988 is the new version of the National Suicide Prevention Lifeline. However, it is specifically being broadened to any type of mental health or substance abuse or suicidal related distress. And of course, there's a ton of overlap between all of those types of experiences. But we really want to make sure that the public understands that you don't have to be in a certain sort of diagnostic category or type of experience to call 988. And yes, it's absolutely for the person or anyone who's helping them.
All right, here's a good question. Will the 1-800-273-TALK or 8255 number go away? If so, when?
There's no plan for it to be retired, but over time, we think that the 988 three-digit number, which has also had, already it launched just, a few days ago on midnight, Friday night, that all of the media and the public messaging, the public awareness campaigns that are going on to let everyone know that just like there's a three-digit number to call if you're in a physical health emergency, 911, there is that equivalent for mental health and substance use and suicide related crises. So right there's actually no plan for the 1-800 number to go away. So either way, you're going to get to the same place, but 988 we think will kind of overtake it over time.
All right, thank you so much. I'm not supposed to interject here, but I want to know, do you feel that, or how do you feel about this new 988 number? Is this going to reduce suicide attempts or suicide completions? It sounds amazing. Can we see the numbers change?
We could. Obviously suicide is a complex health behavior and health outcome that requires a public health approach. But in every instance of the countries that have actually implemented at scale their effective national suicide prevention plans and seen a reduction in their national suicide mortality over time, they all had robust crisis response systems. So it is considered part and parcel to an effective suicide prevention, multi-layered plan. And furthermore, 988 is not just a 3-digit number, sort of a rebrand of the Suicide Prevention Lifeline. It actually has a congressional act and an infusion of money. The appropriation level that went into 988, we jumped up about 30 times the level of financial investment that compared to previous years than our country has ever spent on mental health crisis. And so that is not just for the hotline itself and all of the 200 plus local crisis centers that are part of that network that actually staff the 988 line, but that money will also go into the communities at the county and state level to build the infrastructure of other mental health resources so that it's not just inpatient hospitalization or outpatient treatment and almost nothing in between, but that there would also be mobile crisis response, community respite centers, peer specialists. Some communities have these already. Those are the rare counties in the US. Most do not. And so 988 is much more than just the number and the rebrand of the Lifeline. It's a whole multi-layered investment, if you will, at the national, but now really it's up to states to pass that legislation. So the short answer is yes, I actually feel this is a very important step towards reducing suicide mortality in the US.
That's amazing. And kudos to you and AFSP and every institution involved. I think this is fabulous. I'm going to ask you a very important question. What can people expect when they call 988?
Yes. Calling 988 will get you to the centralized Lifeline Center, which is headquartered in New York. It's administered by a group, a nonprofit colleague group of ours. It's not us at AFSP. It's Vibrant Emotional Health, Vibrant Emotional Health that administers 988. And so when you call, your call will be routed from their central location to your local crisis center based on your cell phone number. And so that means that you won't always get to the actual geographical location you are, depending on if your cell phone is from, the place where you are in the moment. But you should, and I want to set expectations properly. It's not as if there are a plethora of counselors just waiting and a dearth of calls. There are many calls every day. And so there can be some waiting time involved, which is true for other helplines and 911 as well. And we wish that weren't the case, but I just want to kind of set people's expectations that you might be on hold for anywhere from 30 seconds to several minutes, and to just please wait. Now, when you call, you will also be given options. If you're a veteran, you can press 1 and be routed to specific veterans crisis line where there are specialists to interact with veterans. There will be other specialized populations or specialized services, I should say, for specific populations that will have yet to be developed for 988, but those will be options. So there'll be, an automated sort of tree that you go through to say, that you're just a general public member and wait for your trained counselor to come on the line. And that's the other thing I'll mention. Everybody who staffs this 988 line is a trained counselor. That doesn't mean that every single individual is a mental health professional by background. It's a combination. The Vibrant counselors are all mental health professionals, but many of those crisis centers out there in the 50 states staff their crisis centers in different ways by training, in some cases, even training volunteers. So there is some diversity in terms, but there is a standardization of the training.
Wow, that was an amazing answer. And so next question, with 988, do children or youth and geriatric patients receive specialized or different response?
No, so far those are not special populations that are getting, specialized or specially trained counselors. So the trained counselors are equipped to address any member of the public, really regardless of age or race, ethnicity, other forms of identity or geographical area. And again, the goal here is that the calls will be routed to your geographical area so that the resources are more locally aligned for accessing. So no, not as of yet, nothing that's youth or geriatrics specialized.
All right. Here's a question. Does involuntary admitting patients to a hospital when suicidal increase, decrease, or have no effect on suicide completions in the end?
It was the question involuntary hospitalization?
Yes.
Voluntary? Okay. And I don't even need to ask that, because there's no research that really delineates a different outcome based on involuntary versus voluntary hospitalization. And in fact, there is only recently some research really looking at what interventions on an inpatient, in an inpatient psychiatric setting can have the impact that we want in terms of reducing not just the suicide risk while they're in the hospital, but after they leave the hospital. And so it is really important to realize that the period of days to several weeks following discharge from a psychiatric hospital or an emergency department when a person is there for suicide-related reasons, that period after they leave is actually one of the highest risks periods for people. When you look at things sort of chronologically over a life cycle of people who do show suicide risk, that is a very, very vulnerable time. And so there are tremendous efforts to actually do everything from bridging care from inpatient to outpatient, to making safety planning feasible and doable on the inpatient unit, but then equipping the person, their family member, and both inpatient and outpatient teams with some continuity to follow up and continue to utilize the person's safety plan. So there are apps, for example, and those are some that are being researched by Dr. David Brent and others to really make a concerted effort to reduce the risk during that post-discharge period. CAMS is another modality, collaborative. It stands for Collaborative Assessment and Management of Suicidality, Dr. David Job's intervention. That's another one that has been developed, is very person-centered, and is showing reductions in suicidal ideation. And we hope that they'll be able to show reductions in suicidal behavior as well, with more research. But so anyway, that's kind of a tangential answer to the short answer, which is no, we don't have any data that really helps us understand outcomes differences between involuntary and voluntary. That said, I will tell you that the lived experience community in the suicide prevention field, which is very strong, and those are individuals with their own lived experience of suicidal crisis, whether it's attempt or ideation, which, by the way, is not just patients. This is like, health providers, other professionals, anyone who's had their own lived experience, which includes myself. But there is a lived experience community that's very important to include in the development of any research method protocol, any clinical intervention, any new policies at the clinical level, very important to include. And what people with lived experience have told us is that when involuntary hospitalization is, I'll just say, overutilized, and I think historically it has been because of the lack of other resources that I mentioned earlier in this session, that they haven't been available to clinicians to tap into, for their patients. And so we've at times felt hamstrung that in order to just keep them safe in the moment. But what we hear from people is that it can be not only traumatizing in the short term, but that oftentimes what happens over time And especially, and this is complicated, but especially when there's police involvement in that involuntary hold situation, for many people, and especially people from minoritized backgrounds, that can be additionally traumatizing and really create a chasm so that it becomes harder for them to even disclose suicidal thoughts in the future. So it's a very hot topic in suicide prevention. What we're saying is the new frame and the new way to approach care of a suicidal patient is to use the least restrictive measure that is person-centered. And of course, if you're thinking system-wide, you're also thinking kind of the appropriate resource for this level of risk. And that's a lot of different factors to consider, because it's not just about whether the person has suicidal thoughts and a plan in the moment. It's about their historical background. It's about what resources they have in their life, caring, supportive people who can stay with them, make sure that they get to the follow-up appointment, walking through different risk scenarios. If this changes in their life, how might that shape their suicide risk? So suicide risk assessment is not a simple thing, and yet there are now better tools to help clinicians do that work.
Thank you so much, Dr. Moutier. And we have a question from our live chat. Does 988 account for the cultural, linguistic, and other social environmental needs of the individual?
Well, I would say it is the effort is making a great effort to try to do just that. But that is of course, a massive undertaking to truly be culturally humble and trained and inclusive for all the different backgrounds and populations in the United States. But there are a couple of things. There is a specialized services part of the 988 line that will be just for LGBTQ people. So that's really important to have that specialized area addressed in a very specific and informed way. And there is also a Spanish speaking service part of 988. So that's another way, obviously, for Latinx and Hispanic communities to be able to receive more, not only linguistically, but culturally appropriate care. I would just say that the training that these crisis counselors receive absolutely includes some cultural training in terms of being from, for people who are from marginalized backgrounds, including BIPOC people and others. So that is, and I guess there's one more thing to say about this, which is that if the 988 effort, beyond just, if you put it into two different levels, 988 at the top level being this new 3-digit number to call for the crisis moment, but the second and really important level being the ability over time for states to pass legislation that will fund over a sustainable funding source for all those layers of mental health resources at the state and local levels. That is one solution, by the way, to the problem of what has been the de facto police intervention for mental health crises. And then when you have the intersectionality of marginalized identities on top of a mental health crisis with police intervention, that is something that the 988 system is definitely trying to move away from and have those crises met by trained mental health professionals rather than by a law enforcement, primary response.
Well, that leads right into our next question. What training do 988 staff receive?
They all receive a very robust training that is a major effort at Vibrant to make sure that the training standards across all of those 200 plus crisis centers are uniform, so there's fidelity, and that there's also some quality checks and controls to their system. So that is a major effort. And for anyone who's really kind of wanting to dig deeper to this, I would refer you to Dr. Madeline Gould's research of the National Suicide Prevention Lifeline, its former name. but it will be the same quality and the same training standards for 988. And what you'll see in Dr. Gould's research is that not only is the training critical and makes a big difference. She has one paper that looked at assist training, for example, of the crisis counselors, but also there's a study that looks at the actual outcomes of the callers. And they did, it's amazing, thousands of follow-up calls with the callers and basically probed how that went for them, what happened with their suicidal ideation or other forms of distress. And in the majority of cases, the individuals who were studied and part of that research project had major reductions in their intensity or their their current suicidal ideation reached a point of resolution for that hot moment. It doesn't mean that obviously these tap into much oftentimes deeper both psychopathology as well as psychosocial circumstances that do require ongoing follow-up. But the goal of a crisis response moment is to bring that hot, intense, acute moment down to what we call a cool calm. And that is a form of saving a life, because for some who would have acted on their suicidal impulses in that moment, it can not only save a life in that moment, but it's also a way to connect people to those ongoing mental health resources, for sure.
That's amazing. And we have a question here from the chat. Can you explain how the continuum of care and EHR integration, if any, work with 988? Will providers know or be alerted that our patients contacted them?
That's still a major problem, right? Our health systems, whether it's the health system itself or the managed care network, the payer, or if it's through a public, mental health system. I think the public mental health system and the VA probably have some of the better chances at linking up records such that they might be able to see those crisis calls to 988. But, if you're a clinician in a private practice or a group practice somewhere, there, in all likelihood, it's not going to be information that you would be able to receive. So it's actually a very practical point that when you are counseling patients who've had a history of suicidality, or they're becoming increasingly distressed and may reach a point of suicidal crisis, giving them resources for crisis resources is considered part of the suicide prevention care steps. So that would be 988, which does include calling, chatting, and texting. And there is also the crisis text line, another national resource for texting. But you might also then, when you follow up with them, make sure to ask patients if they have utilized these crisis services, if they've called 988, or chatted with the crisis text line. Those would be important questions to ask, and also to remind them that they exist.
Thank you so much, Dr. Moutier. Next question here. This is not about the 988 hotline, but more in suicide prevention. Are there any new promising anti-suicide interventions for patients with substance use problems?
This is such an important area, because we know that the opioid crisis, as well as alcohol-related, addiction and mortality, have risen up to be part of this big, deaths of despair problem that we've heard highlighted over the past several years. And yet we also know that when somebody dies by overdose, many, many times it was actually a suicide, but difficult for medical examiners and coroners to have enough evidence to actually call it a suicide. So we've known for a long time that there's a ton of overlap. In addition, the fact that people with addiction. That is a form of mental illness. That's part of the brain disease that can put people at risk for suicide. And the fact that under the influence, there's disinhibition, which actually may, for a person with acute suicidal impulses, may in fact be their path to act on their suicidal thoughts because they're disinhibited by the substances. So there's just tons of areas of overlap. We've known as a field that we have to come together because the research and the clinicians in the field of suicide prevention and in the field of substance use have unfortunately been sort of historically siloed, but there's a ton of efforts to come together much more on this. And I'm happy to share that at AFSP, where we fund, we're the leading private funder of all suicide and suicide prevention research. There are 2 grants that I found that actually relate to developing new interventions for people with substance abuse problems and suicide risk. And one is an app that actually uses a brief form of DBT skills building for people who have a combination of access to borderline personality, mood disorders, and suicidality. And then there's another one that uses an in-person or via virtual treatment form of motivational interviewing that substance use treatment providers can utilize to address suicidality in their patients. But I mean, at the most basic level, what we need is for all clinicians who are working in substance use treatment settings to be screening for suicide risk universally and routinely. That would be the first step. And then just know that there are steps to take if somebody screens positive. And I would refer people to the NIMH site where the ASQ, the ASK is a very clear pathway for screening and suicide risk assessment that can be used in primary care. It's being used in pediatrics a ton, but also in primary care for adults, but also in mental health and substance use settings. And if you just search NIMH ASQ, you'll come up with that pathway. And by the way, for anyone who's interested in learning more about what the research is coming up with in terms of new treatments, new findings related to the genetics about suicide risk and suicidal behavior, and how that relates to treatment response, how it relates to substance use or other diagnoses like depression, bipolar, schizophrenia. If you put in your search engine AFSP research videos or even AFSP catalog research, you're going to see hundreds of brief videos you can watch, and also all of the publications of the studies that we've funded over the 3 or so decades that we've been doing that.
Thank you so much. And I want to switch over to chat here. Are all individuals that call 988 screened for suicidal ideations?
Yes, I believe so. I should put a caveat here. Some people do call the Lifeline 988 for other reasons, and they may not all be in acute distress, and that is okay. I should point out, for example, there is another line that's related to 988 called the Hope Line that is specifically for people with substance use problems. And not all of them are suicidal. Many of them are looking for resources for treatment and support. So I think that the majority are screened by matter of routine, but I think there may be some exceptions to that.
Well, on that note, will the 1-800-273-TALK or 8255 number go away? If so, when?
There's no plan for it to go away. So no need to stress about, should I change my resource list? I would encourage you to add 988 to your resource list, but it's okay if 1-800-273-TALK is still showing up in lots of places over the next several years. There's no plan to retire it.
That's great to know. And all right, one final question here. Last couple seconds. Many of my patients have felt suicidal and with suicidal attempts, but minimize it or deny it as they don't want to be admitted. What are some evidence-based interventions that can be done rather than admitting someone?
Right. So we're going to run out of time, but the brief interventions I'll mention are safety planning, lethal means counseling, and educating the person and their loved ones if when possible. And then beyond that, if you can get them into psychotherapy, the ones that have been shown to reduce suicide risk are CBT, DBT, some forms of family therapy, and I mentioned CAMS as well.
Well, I think that is all our time. Thank you so much, Dr. Moutier, for joining us. Thank you to our audience for joining us and submitting your amazing questions. And we'll see you next time at Ask NEI.
Awesome. Thank you so much. Take care, everybody. Thank you.